Welcome to Roundtable Conference, an expert policymaking group. We are live on Saturday, 11 a.m. This is live every day on the same platform. We have Dr. K.K. Kalra with us. He's a former CEO of NABH and board member of Heart Foundation of India. Over to you, Dr. Kalra, to introduce the speaker and the topic and to take this discussion forward.
Yeah, thank you, Saurabh. Good morning to all, and I welcome all the participants to this SCFI Expert Group Roundtable session, probably 99th. Today we are having, and topic is life of a surgeon during the COVID era. Dr. Ashok Gupta, who is a cosmetic surgeon, a lot of experience in reconstructive surgery, and a Padam Shri awardee. He will be sharing his experience during COVID time as a surgeon. And before I hand over to Dr. Ashok Gupta, I will just give in brief a little 2 minutes COVID update, and I will request Dr. Jamkar to chair the session. He is also a surgeon. Let me share my screen. सौरभ मेरे को प्लीज स्क्रीन शेयरिंग अलाउ करो. सौरभ, डॉक्टर अशोक को भी. No, Dr. Saurabh.
Saurabh is gone.
Oh my God. हाँ, सौरभ, मैं फोन करूँ उसको.
We are already live.
No. Screen sharing he is not allowed.
Just a correction. I'm more of a reconstructive plastic surgeon than a cosmetic surgeon alone.
Yeah. Sorry.
Cosmetic surgery is a glorifying brand.
No, I prefer to be called as an aesthetic plastic surgeon, not as a cosmetic surgeon. In our opinion, cosmetic surgeon is those who are unqualified plastic surgeons or underqualified.
And sometimes all these cosmetic surgeons are dermatologists also.
Yes, not even dermatologists, not even MBBS sometimes. Some problem seems to be sharing screen. Do you think I can?
Yes, to enable it to you.
Okay. No, Dr. Kalra is sharing screen also.
No, nobody can. He is host.
He is the host. Okay. While we are waiting, I missed your picture along with PM, the Symbiosis, when he came to Symbiosis to inaugurate the program, Dr. Jamkar. You were not there?
Yeah, I was there.
No, in the picture. In the picture which came.
I was in the first row.
No, picture with Rajiv. With Rajiv.
Me and Mr. Modi, there was 21 feet.
No, Rajiv was there in the picture. Rajiv and Mr. Mahajan, Mr. Majumdar. Dr. Majumdar picture was there. Rajiv was there, but I did not see you there in that picture which was flashed all over the country. Yeah, Dr. Kalra, unmute yourself. Dr. Kalra, आप mute पे हैं? हाँ, sorry. Dr. Kalra, you are on mute.
Yeah, now it's fine.
Yeah, better.
Yeah. So, all over the world now, this week also, as compared to the previous week, as a WHO reported week report ending on 8th of this month, overall there was a decline of 5% of new cases and 8% decline in deaths. Except Western Pacific region, All other regions, there was a decline reported in new cases as well as deaths. But from Western Pacific, still this week compared to the prior week, there was an increase in 46% new cases, and death also increased by 29%. Highest number of new cases were reported from Republic of Korea, Germany, Vietnam, Russian Federation, and Japan. And highest number of new deaths were reported from United States, from Russia, from Brazil, Indonesia, and Japan. As we know, all over the world, now it is the Delta is only very, very small. Majority of the cases are Omicron, that is 99.7%. And Delta is only 0.1% all over the world. And among the Omicron further sublineages, BA.1.1 is the predominant subvariant, accounting for 41% of the cases. BA.2 accounts for 34.2, and BA.1 accounts for 24.7, and BA.3, which is the minimum, which is less than 1%. In India, so far, as on date, 179 crores 72 lakhs and 505 vaccine doses has been administered to eligible people in our country. In the last 24 hours, there were 4,194 new cases. This was a data of 12 yesterday's. And today, there are only 3,614 new cases and 89 deaths across the India. Lower down, we can see during the COVID era, the graph, new cases, tremendous now downward trend, as well as deaths compared to the second wave, third wave is very, very less. And now they are also declining, only 89 deaths the last 24 hours. Kerala, which was one of Kerala, Maharashtra, Karnataka, and Delhi, which were the highest states contributing to the COVID during the third wave. Even yesterday also, Kerala reported 1,614 on average weekly basis per day. And today, Kerala has reported 1,175 cases and 73 deaths. Maharashtra only 417 cases, and today 318 and 1 death. Delhi has reported 174 new cases today, no death, but is a Mizoram state in India, which is still contributing, although very small state, but still contributing 403 cases and 2 deaths today. Goa and UP, the election gone states. So recently they had elections. Even there, from there also we can see in Uttar Pradesh only 107 cases in the last 24 hours and 4 deaths. And similarly, Goa also now declining trend. There was no increase in cases of COVID during this election campaign. This time it was seen, not seen. South Africa, we can see the declining trend. Bangladesh, Nepal, Pakistan, all are showing a declining trend. And Russia still reporting on average weekly 71,000. Sorry. 71,159. Australia also reporting 29,422 weekly average new cases. Thailand also is now reporting average weekly 22,093 cases. United States Now there is a declining trend. They are reporting on average weekly per day around 36,537. Japan, you can see, still reporting very high number, 56,676 on average weekly basis daily. Germany, 1,83,313 cases on average 7 days. New Zealand also has shown for last few days, but again it has shown declining trend. All the small countries were still reporting almost 17,018 cases per day. United Kingdom still showing around 77,286 cases on average weekly basis. WHO has recently given an alert that now, although in humans all over the world cases are declining, but there is a possibility of animal reservoir may pose a problem. As with during the COVID time, a number of initially, especially during the second wave, a few outbreaks in the animal were reported from few countries. Last was in January this 21 in the deers in America and other European countries. So if these animals now start acting as a reservoir, which may give rise to new variants and which again may jump from animals to human being. So there is a risk. And in India, seeing the trends and declining number of cases from 27th of March, international flights will be resumed after 2 years' time. Recently, DCGI has approved in India a Viralex drug, which was based on the randomized controlled clinical trial to be used in mild and moderate cases. This Viralex is an immunomodulatory agent with a broad spectrum antiviral properties. It enhances both the innate and adaptive immunity and strengthens the body's defense response to viral infections. So this is basically, generic name is Inosin Prabanobex. So this was all about COVID update, a little brief. Now over to Chair, Dr. Jankar.
I just wanted to add, Dr. Kalra, for excellent, appropriate presentation. I was joining the first part of the meeting where the expert from Bangladesh pointed out article in Lancet. I think everybody should read that, where it is very inappropriate. And it says that the deaths in India in COVID are 8 times high. And I suppose everybody should read, and Dr. Kalra, you should write down an answer to them. Because we might have increased number of positive cases because of the kits. But then once the patient becomes serious, they get hospitalized where they die. Then they have to have RT-PCR, and we don't do RT-PCR without Aadhaar. So I don't think we are opaque in any area. So I suppose.
I think central government also has given their views. They've antagonized this report of Lancet. I read that report.
But then, if you write to Lancet as a letter to editor, it will publish. Maybe in case उनकी नियत अच्छी है तो publish कर दे.
चलो
Anyway, I welcome Dr. Ashok Gupta for a very appropriate presentation, which might interest people, because he has been working during COVID times, was one of the hardworking surgeon, and I think he was participating in all those hospitals which were COVID hospitals in COVID era. So his experience would be guiding for all of us. And I know he has been working in various fields. He's in fact, he has a lot of social obligations, and he is indeed, briefly say, he is a role model as a surgeon. Over to Dr. Gupta.
So before you head over to Dr. Gupta, I would like to have a comment from Dr. Anita to this WHO alert regarding animal reservoir for COVID-19. Dr. Anita, she's there.
Yes, they think that there are other animals could be potential source, because also bats is not 100.
Yeah. You have gone.
Look at me.
Yeah, now I can hear.
So bats is was also, from bats they passed it to other animals.
Yes.
So there is a chance, and I hope it does not occur. Then we're in trouble.
Okay.
Gupta.
Dr. Gupta.
Thank you. Thank you, Professor Jamkar. Thank you, Professor Kalra and all others. Can I share my screen?
Yeah, please.
I suppose, yes.
Is it clear? Is it clear now?
Yeah, you share. Yes. Yeah, it's visible.
Yes. Thank you.
You maximize it, please.
Yes. Yes. I mean, it's a very interesting and very challenging topic, and I'm sure all of us, those who have a surgical background, will appreciate the contents. It is not based only on my experience, but also some of the global experience and the American College of Surgeons and American Society of Plastic Surgeons guideline and WHO guideline. So these are the challenges in the life of it, and particularly in major surgeries, including mine, which is microsurgery, many times runs up to 18 hours or 20 hours. So there are definite serious challenges in undertaking such procedures. And I would like to share some of the international data and reports based on guideline how this such surgery should be undertaken. Now, as we all know, COVID pandemic has given rise to feeling of fear, anger, and helplessness among all surgeons. Virus has changed the outlook of surgeons to provide care, and it's still extremely stressful to coping with the financial distress which most of the surgeons are faced to during this last 2 years' time. Now, surgical care, without any doubt, surgical care is a foundation of any health system, whether it is elective or emergency procedure, and contributes to the critical services which are being offered to the population by all type of healthcare providers. It is essential to act thoughtfully and to support the hospital surgical care system, as well as protecting the benefits of patients, at the same time conserving the resources of the hospital and protecting the staff which are working. Because initially when the second wave came and the first wave came, there were instructions to stop all elective surgery and to undertake only emergency procedures to basically to conserve the hospital resources reservoir. And I have gone through that stage when even getting a gown and glove was such a scarcity to perform emergency procedure. Everything was reserved for the patients for the COVID. So now COVID-19 pandemic, as we all know, has had an extensive effect on surgeons and patients who require surgical care. Providing care for surgical disease requires an exclusive and intimate relationship between the patient, whether it is COVID positive or COVID negative, and surgeon. And this interaction and contact cannot be replaced by a telehealth system of medicine, which almost all other branches of medicine can be implemented effectively with telemedicine system, except surgery. Now, financial effect, if we go by this thing, financial effects of surgical shutdown has been far-reaching.
Dr. Gupta, make it full screen.
It is full screen actually. I made full screen.
No, yeah.
Maybe it is covering part of the.
Make it F5.
F5 I have made it. Control F5. Yes, it is F5. Yes. Is not visible?
No, it's visible. It's not full screen.
From my screen, it's coming as you are screen sharing. It's coming as a full screen from my side.
Where?
Okay. Just want to.
Just change the slide, I think.
Yeah, yeah. The financial effect of surgical shutdown has been far-reaching.
No, it is not changing. Slides are not changing, sir.
Yeah, I'm changing it. It's changing now. Is it changing?
No,
it's not changing.
I will re-log in then.
Yeah. Maybe stop sharing and share it again.
Yeah, share it again. Is it now visible?
Yeah, no, same slide.
Changing?
No.
No.
Okay, let me.
Should I share?
No, I've made some changes. Let me do it again. I will close that and then. I'm starting a new one from the. Is it better now?
No,
Slide
it's
is
not,
not
we are not
seen.
able to see.
We are not changing.
No, slides screen is not coming. Only your list of this coming.
File manager.
Okay, okay, let me. This is the screen which I have. Yeah.
Now, yeah, now it is fine.
Okay. The now this is not changing from my side. This.
Okay. You,
Is it better now?
No, not changing. Same thing.
No, the slide is not changing.
So इसमें आप एक बार दोबारा शेयर करो.
आप माउस यूज कर रहे हैं या?
नहीं, मैं दोनों कीबोर्ड यूज कर रहा हूं मैं.
Make it page down.
Can you open the presentation?
Is it changing now?
नहीं, open the presentation. It is closed.
अभी आपकी वो विंडो दिख रही
एक्सप्लोरर
है.
आ रहा है. अभी तो विंडो एक्सप्लोरर आ रहा है.
मैं पूरा क्लोज करके फिर से करता हूं मैं.
हाँ.
इसमें आ रहा है. They can see now. Is it better now?
Yeah. No,
Yeah, now it is better. Yeah.
Now, financial effect of surgical shutdown has been far-reaching. Many of surgical private practices could not withstand the pressure and either have shut down or have relocated themselves. Some surgeons have retired early or decided to leave the surgical specialty and change over to some other aspect. These problems further influence the surgical workforce during time, and during these there is a likely greater need for a surgical care. Now, how we adapt to new normal. Now, COVID and surgical practice prepare for a rapidly changing situation. Postpone elective operations immediately. Develop a dedicated operating suites. How long the surgery is likely to be, and will the patient be needing a ICU care after surgery? I mean, this has directly affected my own nursing home, which I used to do all aesthetic procedure, and lasting for 8 hours, 10 hours, I had to shut down because I cannot afford to have all those parameters. So will the patient be needing a ventilator during or after surgery? How much blood loss during the surgery? Number of surgeons and nurses needed at the time of operating room? And is the surgery in the lower risk group or an higher risk group? Now, there's a trial suggested by American College of Surgeons, which is very useful and which is applied all over the world as a guideline for this. Now, first fundamental question to surgeon: is it worth the risk operating on a long patient or sick patient for long surgery or major surgery? There's a COVID surge. There's a COVID surge collaborative. A global study has been formed, which has published its report in October 2020, and it states a very grim picture. For every person who undergoes surgery during the COVID-19 pandemic, 1 in 4 chances that they will die, and 50% chances that they will suffer severe pulmonary complications. COVID surge has expanded participation, doubling the number of hospitals and tripling the number of countries. 733 hospitals across 73 countries and more than 24,000 patients have been enrolled. And this information is invaluable, and everyone wants to have detailed study. of the risk-benefit ratio being shared by the study. Now, surgeons urgently need guidance on how to deliver surgical services safely and effectively during COVID-19 pandemic. The aim was to identify the key domains that should be considered on developing pandemic preparedness for surgical services. The surgeon did not have any information about how COVID affects surgical patients. Current study tracked more than 1,100 patients who underwent surgery. About 75 had emergency surgery and 25% had elective surgeries. The Lancet in his report has mentioned that that patients testing positive for the virus 7 days before or 30 days after surgery are at potential high risk group. Now, there is also another publication which is Surgeons' Voices in COVID-19 era. 1 in 4 patients infected with the virus before or after the surgery died. 1 in every 2 patients contracted serious pulmonary complications such as pneumonia, acute respiratory distress syndrome, or unexpected post-operative ventilation. Type of anesthesia used, general, regional, sedation, or local, did not alter the outcome. And it reminds us that COVID is not only a lung disease, but it touches almost all other systems of the body. The biggest shock from this study is that the patient may survive the surgery, but still has got high risk of developing serious complications or even death than there was before the pandemic. Impact of SARS-2 COVID-19 on post-operative pulmonary complication and mortality needs to be established to enable surgeons to make evidence-based decisions. The American College of Surgeons has created a triage guideline for COVID-19, and I will go a few important points on that. Hospitals and outpatient surgery centers should consider their patient need and logistics of capability to fulfill them in real time. Need for a procedure should be established by a surgeon with expertise in the relevant surgical specialty to determine the damages be sustained or while delaying or denying the surgery, and feasibility of procedure be determined by administrative personnel accepting the hospital facility, safety and well-being of the patient and staff. The risk of patients should be include an aggressive assessment of the real risk of proceeding and the real risk of delay. Finally, COVID-19 is a clear risk to all, and it is but one of many competing risks for patients requiring surgical care. Surgical procedure should be considered not based solely on COVID-associated risk, but rather an assimilation of all available medical and logistic information. Benefit of creating COVID-19 free zone within the hospital is a very, very vital parameter which is recommended strongly. COVID-19 positive are not mixed in the area, minimizing the risk of accidental area. COVID-free zone must be established, protecting patients opting for surgical elective and during pandemic time. Again, hospitals should prepare detailed specific pandemic preparedness plan addressing the identified domains. Specific guidance should be updated continuously to reflect the emerging evidence during COVID-19 pandemic. The backlog of procedure after the end of COVID-19 pandemic is inevitable, and hospitals should plan to report effective method to ensure that patients for elective surgeries have the best possible outcome after the pandemic is over. American, again, they have prepared a roadmap for maintaining essential surgery during COVID-19 pandemic, and I will share some important points. Balances, this is called as a ESAS, which is a elective surgery acuity scale, and balance patient need or impact of a surgery procedure with available sources. Planning for resuming surgery should take into account the perspective of multiple stakeholders, including surgery, anesthesia, nursing, and facility administration. Elective procedure can be delayed until he or she is no longer infectious and has recovered fully. Impact of severe, we all know, acute respiratory syndrome on postponing post-operative recovery must be understood to inform clinical decision-making. The international This is a study which is international multi-center cohort study at more than 224 countries report 30 days high mortality and pulmonary complication rates in patients with preoperative or perioperative SARC infection. So this is a very, very grim picture. Said again, the American Society of Plastic Surgeons, which is almost representing more than 10,000 members, there is reported most members stopped performing elective surgery procedures for an average about 28.1 per week in 2020 during the COVID, or which is 45% of their annual thing. More than 2 years, COVID-19 has largely confined people to their homes and have significantly impacted nearly every aspect of their life and aesthetic surgery which people were performing, including tummy tuck, facelift, and all sort of things. Now, in place of that, injectables have grown. The injectable procedure like Botox and fillers have continued to be the most sought after treatment in 2021, which is a solace for us, but a financial loss. Safety issues in operating room using N95 mask, face shield, eye protection, double eye layer PPE are common practice, but it adds to the hazard of a surgeon for performing long duration surgery. Sometimes patients are so sick that need to perform operation in the ICU, and this is also one of the biggest challenges for surgeons in emergency procedure. Last week I reviewed an article for Annals of the National Academy of Medical Sciences, where a surgeon was called to do a compartment syndrome in an ICU patient. That's a rare complication of COVID when he developed a thrombosis and compartment syndrome of the forearm, and the surgeon had to do decompression in the ICU itself. So sometimes patients are so sick that they need to perform operation in ICU, not as sterile in an operating room, and they're associated with a lot of risk. So again, as a surgeon, when we are using cautery, universal use of smoke evacuators to suction away the smoke plumes generated by electric cautery has been encouraged to minimize the risk of exposure to aerosolized tissue. Precautions should be taken for surgical cases to minimally invasive procedure that requires the creation of pneumoperitoneum must be safely managed or avoided if possible. And Dr. Jamkar can give an expert comment the role of gases in laparoscopic surgery, how safe it is now in the COVID era, and what are the risk of complication with the pulmonary complication with higher gaseous inflation in the laparoscopic surgery. A patient is always informed about the risk before a surgery. Now we are letting them know their risk is even greater. Pre-operative patient could test negative for COVID even though they are infected. 2 to 14 incubation days period is there. We know it could be false negative. Patient may not be infected but could contract the virus while at the hospital or within 30 days of the post-operative period. So again, so my concluding few remarks, that no system is foolproof or a foolproof. At our hospital, we are doing everything possible. We can maintain the sterilization. And my own theater complex with our operating, we have about 7 theater complex. And on an average, we used to operate about 150 to 200 patients a day. And that number has come down to not more than 30 cases a day. I mean, that has been drastic down, which combine all general surgery, gynec surgery, plastic surgery, and cancer surgery. We have a separate theater for orthopedic, separate theater for neuro, but the rate is almost same everywhere. It is drastic reduction in the number of cases which are coming for operation. Again, the transportation to and fro from the room, elevator, post-operative room, etc., can transmit infection. Despite all the efforts to minimize the lift which are going to the COVID area, we still have some issues. Patient to be quarantined for 30 days post-operative and pre-operative, so that they do not have any infection, contact infection, etc. Even if it is a minor procedure, is what we recommend most of the patients. And it's a really, thank you for all, and it's a really a sad story that life of a surgeon, which used to be a very lucrative branch and a prime specialty at one time, has been reduced to I would not say to the bottom. It is almost a negligible force in the current COVID era, and we are all happy to sustain the pressure and continue surgical care as and when it is required in our hospital. In plastic surgery, our incidence of attending to CLWs, incidence of going to the hand injury, etc., is drastically reduced because we say let it be attended by the general surgeons or other specialists. Thank you once again, Dr. Kalra, and thank you, Dr. Jamkar. This is, of course, a very brief presentation of the life of a surgeon, sharing some of the international experience and some of my experience. Thank you once again.
Please stop sharing screen.
Yeah. Thank you, Dr. Gupta, for very elaborate presentation on the life of a surgeon as well as what he does during his life. My question is now it is more pertinent to find out how to handle post-COVID cases, because I think everybody who is now undergoing surgery, who has a history of COVID, so how will you investigate and find out whether he is suitable for surgery? Because many people are developing pulmonary fibrosis, and because it's a polycystic disorder, it almost involving every system. So I think how will you investigate these patients before you take for surgery?
See, in my case, I would say in my specialty, I was very fond of doing abdominoplasty, repair of the ventral hernia, and lipectomy, etc. And as part of my procedure, it was mandatory for every patient to get a PFT test done. I used to do intraoperative monitoring, intraperitoneal, the intra-abdominal pressure monitoring before doing plication of rectus, etc. But post-COVID, knowing that there could be patients, those who are recovered from COVID, they have a potential risk of pulmonary complication, fibrosis. So literally for last 2 years, I stopped doing any abdominoplasty, repair of the ventral hernia and liposuction because they carry a potential risk of complications and this thing. So this is very, very vital. Now we have to understand the limitations which are caused by the post-COVID recovery. All these, we know, all these patients post-COVID recovery, they have a residual pulmonary limitations. They have residual systemic limitations. So we have to analyze that. And there comes many a time when I refer to patient to a physician, their standard note is patient is fit for surgery. Now the surgeon has to calculate the risk with his procedure. A physician or anesthetist cannot give a risk assessment of surgery. So it is very, very vital for Professor Jamkar and person like me to individually, specialty-wise, develop a protocol, do the risk assessment of laparoscopic surgery. I mean, we say cancer surgery, there's no alternative, it has to be performed. Most of the surgeries there's a study which says if the surgery is less than 2 hours or less than 3 hours, the risk of complications are much less. But if the surgery is more than 4 hours, the risk of complication, the pulmonary complication almost become double. And 99% of our microsurgery is for more than 10 to 12 hours time. So it's a major risk.
And any concern about coagulopathies and non-pulmonary, what you call as advancements of post-COVID era?
Yeah, these are also serious challenges. We don't understand. I mean, as a surgeon, we hardly paid attention to coagulopathies, etc. We were happy doing PTR and other tests and then contribute that. But now, although it is a very rare complication of going into coagulopathy in plastic surgery procedures, but it is there. An acute, I'm treating a patient with a diabetic ulcer, and we are thinking of doing it because all gone, so we are thinking of doing a free flap. But then again, coagulopathy, other thing, is restricting us to do any major procedure, etc. So this requires a very elaborate interspecialty and multi-specialty assessment of patient with a complete risk of coagulopathy, what you mentioned, complete risk of non-COVID pulmonary complication, complete risk of healing effect of on the tissue, large areas. And particularly when we do microsurgery, free flap, and particularly when you do in children of brachial plexus, this is a major challenge, how to undertake surgery for 10 hours and 12 hours on a child under full anesthesia without muscle relaxation, because we need to stimulate the nerve in between to test which muscle is working, which muscle is not working. So these are all highly specialized areas of microsurgical work.
Yeah. And I suppose all surgeons across the globe should be encouraged or or not surgeon, physicians as well, to encourage the incidence, the case report of all post-COVID complications. So there might be several, and anyway, at present, all these publications are available without peer review, and they get say rapid publication. So that something happening first time has to be reported, so that people at least will scan and find out whether there are any such things in his patient. So I think we should encourage people to publish and maybe say share on the network.
Sir, may I ask?
Yeah, Dr. Gupta.
Sir, Dr. Gupta, in the literature, there is a report of increase in cases of amputations during the COVID time, especially the diabetic patients. Is there in India also similar cases, some because of the delayed presentations and poor follow-up in these patients, because almost during the COVID time, and especially in the first and second wave, there was hardly any follow-ups, or patients were not being seen physically by most of the doctors, not only surgeons, even physicians also. It was more of a teleconsultation. There was an increased number of cases of particular groups amputations, I remember, in the Western literature. What is your experience in India on similar experiences?
Yeah, even in my unit of plastic surgery, there have been number of cases which have been admitted with the post-infection diabetic feet with a lot of serious complications and sloughing and necrosis, etc. And that has again been attributed to delay in reporting to hospitals, ignoring that, and relying more on a teleconsultation without paying attention to the foot, and with the stress, etc. But this is also a very, very important point, that the surgical care cannot be delivered through telehealth system.
Yeah.
And it has to be stressed upon by someone. If is dealing with a diabetic foot, they have to physically be examined. They have to go to the nearest center for doing this. And they are, of course, apart from the diabetic foot, also there are so many other cases where, as a general surgeon, as a orthopedic surgeon, there are so many emergencies which have been, which has been probably delayed because of the COVID situation, and the patient have ended up in some serious complication, and they were attributed to COVID death, maybe because of the surgical complication. But this risk of post-surgery complication because of COVID or during COVID is very, very significant, and this increases, and that is what even our textbook in aesthetic surgery, where I've written a chapter on ethical consideration in aesthetic plastic surgery. We have mentioned that there has to be special consent being written whenever we are doing a elective procedure in a COVID era, that despite all the investigation, despite all parameters, you still carry a high risk of developing unknown complications and sequelae, which can even result in death. And that should be well documented before undertaking any procedure. How many patients agree to undergo surgery with the risk of death is something which is wide open.
And another challenge, how you were able to manage, because during the COVID time, many of the healthcare workers, staffs, they suffered from COVID, and suddenly on a particular day of procedure, you come to know so-and-so person is down with COVID. How you could manage with the understaffed?
No, only option was for me to close down my nursing home. I shifted all my practice to hospital base, so that I just do consulting. At that too, I go only alone, and the one assistant who takes care of cleaning and patient. Because we don't know, the travel was restricted, areas are restricted, we don't know who is carrying what infection. We are doing in hospital. Unfortunately, hospital staff, although we expect all hospital staff and theater staff should be tested for COVID regularly, which is not practical, which is not being done. Yeah. We don't know who are carrier, who are the actual suffering, but still we have to take precaution and undertake the surgeries I'm lucky that I'm operating in a tertiary care hospital, which is one of the best setup in the country. But what is the risk people are carrying in a government-run hospitals and a poorly equipped hospital and secondary in the secondary B type city and C category cities? So it is a major risk for all surgeons. Many places they don't have a disposable gown. They are using the glove also. I mean, when I joined, I remember when I joined in GT as an honorary, we were not using disposable glove. We were reusing the glove, and many of the hospitals still the same practice is going on. So it's a surgical field is otherwise very glamorous, but at the same time, the biggest beating which has come to the because of COVID has come to the surgical specialist.
Yeah. My last
think,
question.
we must
My
place on
last question to Dr. Gupta. Now, learning from this COVID experience, now COVID is fading away. What is the new norm you will like to continue as a surgeon in your practice?
I think the first thing which I have realized now during this PG counseling, which is happening or which is likely to happen in near future, this surgery will be the last. The specialty like pulmonary medicine, virology, and pathology will be the first priority for the people, because people have realized preventive aspect is something which is going to grow. This is not the last pandemic, and this is going to happen for next 10 years time at least. So people are opting more for these specialty which are in demand now. Surgeons, and particularly otherwise also the need for general surgeons was the craze for only to go into super specialty. That is also getting reduced now. The people are less opting for plastic surgery than they are going for urology and thoracic surgery than plastic surgery. That is one thing. Second thing, sorry, which I feel the second thing, which as a surgeon, you must maintain the risk-benefit ratio of any surgery. As I mentioned in my practice in the last 2 years' time, I have not undertaken any aesthetic procedure which could be delayed. Abdominoplasty, facelift, which is close to face, which has got high risk of complication. The liposuction, which has got high risk of pulmonary embolism, etc. I have reduced that practically not done in the last 2 years' time. So this is what has to be maintained by a surgeon, because even if you've done 10 patients successfully and one death, will reverse all your 40 years of goodwill to the patient.
Yes.
It's a very, very critical period.
Yeah.
Professor Jamkar.
Shall I conclude?
Yes, please.
Yeah.
I think I appreciate the excellent presentation, which is appropriate by Dr. Gupta. I must place on the record that the sacrifices made by healthcare workers are all ignored. Sometimes, if at all you want, you call them warriors and all that. But then all the credit of handling the COVID pandemic effectively is never given to healthcare workers. But then at the same time, what we should be proud of is science has taken its role in reducing morbidity, mortality, and say making a life of people far better, even in this pandemic, which explored all possible domains of science. I think let us celebrate what science has done for a betterment of healthcare in COVID pandemic. So with these remarks, I think I conclude, and I will take permission of Dr. Kalra to end the session.
Thank you, sir.
Thank you. Thank you.
Thank you, Dr. Ashok Gupta, for a wonderful presentation and sharing experience of a surgeon. And thank you, Dr. Jamkar, for chairing the session today. Now onwards, we will be having these meetings Saturday, every alternate day, week. And we should make all efforts to increase the attendance. Otherwise, it's not actually seems
No,
to be.
my request will be all those who are listed in the email, and there were almost 55 to 60 people in the email list which Dr. KK used to send us.
Yeah.
So maybe on one-to-one basis, you can speak to them, and then
I'm trying to speak to them. Even then, after now 3 weeks, today we see.
yes.
Okay. Now we'll see. We'll discuss sometime later.
Okay.
Thank
We
you.
should shift to some nice presentations outside COVID. So
Yeah.
that,
Definitely, the COVID is not the only mandate for our discussions. We can go beyond COVID also. There's some interesting new topics of
So-
interest to the public.
Maybe Dr. Kalra, if you are planning for next fortnight, and with Dr. Anita has also mentioned the fate of medical graduates outside India. If you can get a good panel to discuss on that.
That if you can arrange a panel.
No, I can get two of the ex MCI secretary, Dr. Sharma, Sangeeta Sharma, and Dr. Nair, Reena Nair.
We never.
I can also ask the panel members, panel discussion on GAPIO conference. Maybe we can write down to them as well.
Yeah, I mean, I know Sangeeta Sharma is very well versed with this, and some other Dr. K.K. Talwar can be invited.
Dr. Sunila Garg, Dr. Kalra,
Yeah,
she's
Sunila
quite
Garg.
vocal about
Even
it.
I have spoken to her. Even again, I will try to speak to her.
Or Dr. Kaul at Maulana Azad. She was constantly supplying the information and working on the minimum standard.
Yeah, we will definitely. I will talk to them.
Arun Agrawal. We have so many people, those who are directly involved with MCRD.
Yeah, I think Dr. Agarwal can also take the lead because he's been dean for so long.
Yeah. So
And he gives a very good, he talks in a very good way. So it doesn't like.
I think this is a very vital topic.
We will talk to him. I will talk to the whatever names we have, the group has suggested. Let's see.
And Dr. Shashank Joshi, if Dr. Jamkar or Dr. Ashok can talk, I
Yeah.
think he's in a good position. He could give his viewpoint. I think it will be very interesting.
Actually, I was in charge of the committee which was giving registration to overseas graduates, particularly from US, UK, and there were 5 countries that exempted. And we have gone through what is the system, etc. So they could be very useful. You can get this.
Dr. Kalra, I don't mind if you are extending outside COVID. I don't mind giving a talk on mirror neurons and surgical skills or something.
Oh, that's fine.
Because that is one.
Yeah. I will discuss with you after the session.
Skill development.
Okay.
Development.
Yeah, definitely. Okay, sir. Let's
Thank you.
conclude the
Thank you.
session.
Thank you. I think we should continue the session. The show must go on irrespective of
So
whether
definitely
COVID or
it's go
non-COVID.
on, but frequency we have to do, and timing, if required some time, maybe probably more member can join if time is changed to afternoons. I will talk to 4 or 5 people, and as per the discussion, let's see the same or afternoons after lunch, weekly, or it will alternate week. We'll discuss.
Actually, 11 to 12 is a perfect timing. When finish our morning.
Dr. Mahesh Verma, he is unable to join at this 11 o'clock. He is comfortable at 2 o'clock.
That's okay.
Then we have to talk to
people
and what's the comfortable time for the majority. Then accordingly, we will take it forward.
Okay. Thank you.
Okay, sir. Thank you all.
Thank you.
Thank you. See you next time.
Thank you.